Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy. You guys managing to find time to practice or like listen during the week?
Oh
Yeah.
Drive, so
Yeah.
that helps.
I mean, that's the whole key, man. Just like keep rehearsing those, like your sound bites, and signing up to be an examiner helps just as much. I mean, I thought everyone did awesome last week. Those are some good cases. Everybody did well as the examiner and the examinee. The questions were fair. It was really good. Let's do this. Who's up first? So yeah, practicing for orthognathics, it's going to be kind of fun. This was one section that I felt really good in, but everybody feels good in some section or another. Some people like didn't need to study TMJ that I knew. Anyway, orthognathics were pretty useful overall. So let's go. What time is it? 8:08. 8:08. All right, so Nick, you have a 31-year-old female. Chief complaint, I want to have my bite fixed. She comes in looking like this. What do you want to know?
I still want to know a little bit more about her HPI, what she doesn't like about her face as well. And then a little bit more about her past medical history, medications, surgeries, allergies.
Good.
And
Yes.
social history.
So she has no past medical, surgical, social history, no pertinent allergies. She says that a lot of times she finds herself breathing through her mouth, not because of anything she can point out in particular, but she breathes through her mouth. She doesn't feel like her bite is quite right. Can you walk me through what you see in these pictures here?
Sure. The first picture is a frontal view showing, looks like the eyebrows are gender appropriate. Her alar width is appropriately, it approximates the intercanthal width. Her upper lip width appears to be quite thick, but her width of her upper lip appears to be somewhat approximate to her intercanthal distance. Looking at her, let's see here, there's no vertical dystopia either. Looking at her profile picture, it appears that her malar projection is decent. And then moving on to the intraoral photographs, it appears, no, you're good. Let's see here. It appears to be good gingival health, open bite with, it looks like an Angles 2 classification.
So with regards to the dimension of the lower third of her face, how would you say it compares to the other facial thirds?
The lower third looks elongated, so she has like a dulcicephalic profile.
If you had to give her a diagnosis right now, what would it be?
I would say, so
is this a dental or a skeletal problem you see right now? Is it, assuming she's 31 and
it appears to be a skeletal issue, mandibular sagittal hypoplasia with apernathia and a class 2 malocclusion.
Okay. Assuming her pano sort of looks like this, assume both findings are pretty consistent with each other. What would be your surgical plan?
For this particular patient, I would do a segmental Lafort osteotomy with a BSSO, and her chin looks pretty good, so I wouldn't necessarily do a genioplasty, but I would still present her for one just in case.
The orthodontist gets her appropriately decompensated, leveled and aligned as much as he can. What the orthodontist is asking, though, how many segments are you going to divide the maxilla into?
I would do 3 segments.
And can you describe your reasoning?
Yeah, so the reason I would do 3 segments is so I could drop that, like I would do between the canine and premolar on both sides, so that I have that canine to canine segment that I could just drop down into occlusion.
Sure. So what does your consent consist of? What are you telling the patient before the procedure?
I would consent this patient for Lafort 1 osteotomy segmental, the bilateral sagittal split osteotomy. I would let the patient know of issues such as pain, bleeding, swelling, infection, malunion, and she may potentially be wired shut afterwards.
She's asking, how long is she going to be on a soft diet, non-chew diet?
So I typically put these patients on a soft diet for 3 to 4 weeks.
Okay. So you're in the OR on the day of, and anesthesia is asking you, Doc, anything special for this procedure?
So I would let anesthesia know that the patient may be wired shut afterwards, nasal intubation, Foley, monitor urine output. Procedure is going to be about 8 hours. The need for hypotensive anesthesia during the Lafort 1 down fracture.
So patients prepped and draped. Can you describe what you're doing? Describe your approaches.
In this patient, I would do the maxilla first. So what I would initially do is establish an external reference point from the medial canthus of either the left or right eye down to the incisal edge. And then I would inject local anesthetic and make a vestibular incision from first molar to first molar through mucosa down to through periosteum down to bone. And then I would start to expose the buttresses, the nasomaxillary buttress, ZM buttress, and then also the down towards the pterygoid plate area. And I would also want to visualize the infraorbital foramen, just so I could protect that nerve, and may have to deskeletonize it a little bit so I don't put too much stretch on it.
What order do you make your osteotomies in?
I start with the ZM area, and then I do the piriform osteotomy, and I save the pterygoid plate osteotomy for last.
Sure. So you're able to do your osteotomies just fine. You said you use medial canthus to incisal edge for your external reference?
That's correct.
Yeah. So you down fracture the maxilla, and you get some pretty heavy bleeding that you can't visualize, and the maxilla is not mobile enough to down fracture completely. What's your thinking here? What are you going to do?
I would first start by putting pressure to the area of the bleed.
Pressure doesn't work. What next?
Okay. And I would add in some thrombin with neuropatties and put that in there. Okay.
Let's say that works for a little bit, but you still can't get this bleeding under control.
And I can't down fracture it. So I would actually reposition the maxilla to its original position.
Okay, good. You get the bleeding to stop afterwards, complete your osteotomies, down fracture just fine. Can you describe your bilateral sagittal split?
Sure. So after anesthetizing the patient, I have the bite block in. I would make an incision in the lateral vestibule, leaving enough cuff through mucosa, submucosa, through the pterygomasteric or through the pterygomasteric sling down to bone. And I expose the whole lateral surface of the mandible and part of the ascending ramus, so I could visualize the lingual aspect and visualize the lingula. I would make my horizontal cut above that lingula, and then I would do a gentle S curve all the way down.
Where are you extending your osteotomy until in terms of anterior reference?
I would extend that down to the first molar area, and that's when I would drop my vertical.
So you're proceeding pretty nicely. The resident you're working with decides to go in with osteotome Smith spreaders, and you hear a magnificent crack, resulting in something like this on his side. How are you going to proceed?
Okay, so there appears to be a bad split here. So I would complete the osteotomy at the inferior border, and then I would fixate that mandible that bad split, just like any other mandible fracture. And if it's stable, I will continue with the procedure.
Yeah, I actually want to see if I can give you control of the mouse to show me exactly like where did you say you'd fixate it?
Yes, I would fixate that bad split where the arrow is pointing.
Okay. And fixate it how?
I would put 2 plates, one at the inferior border at the compression area, and then another plate at the superior border there as a tension band.
Okay. And that's just to stabilize this buccal segment.
Yeah.
Are you going to proceed with your surgery after doing it?
If it's stable, I would proceed.
Yeah, assuming it's stable.
Yeah. Mm-hmm.
Okay. And how would you go about fixating this side? What would your
for this particular case, I typically do inverted L screws, but here I would do like a dog bone plate across the BSSO osteotomy.
Mm-hmm. Okay. Assuming you get through that just fine, you get good occlusion, reproducible occlusion after you remove the patient from IMF. How long are you leaving the maxillary splint in place?
For this case with a bad split and everything, I would leave it in place for 3 to 4 weeks.
Yeah. So a couple days afterwards, you notice that there's a small fistula in the palate. What's the potential cause of this?
It was likely due to this. When I was doing the segmental osteotomies, I perforated through the mucosa.
Mm-hmm. What would be your approach to handling this fistula? Assuming it's been about a week now. Fistula is about 3 millimeters in size.
Okay. Does the patient have any symptoms or anything like that? Or
yeah, when you ask her to close her nostrils and breathe out, you see some bubbles.
Okay. I would probably wait a couple more weeks to see if it closes on its own. It's only 3 millimeters.
Yeah, it's not that big.
Okay, so I would just observe it for now, and have this patient follow up with me on a weekly basis to monitor to see if it's.
What if it didn't heal? This is 2 weeks after now, and it's persisting there.
So if it didn't heal, I would repair it. 3 millimeters in the palate. So I would excise the fistula and then just repair it with a palatal rotation flap.
Sure. You're done. That's pretty good.
Thank you.
I know it's nerve-wracking. You had a couple different complications there.
Yeah.
That was a little more than 12 minutes. That was around 14. Overall, I thought you did well. Let's see if I can go back here. There's a bunch of different ways orthognathics can go. This was a pretty routine case. Overall, I thought you did well describing it. I'd say if you know the case is an orthognathic case, try to jump to like the meat of your physical exam a little quicker. Like, if intercanthal distance and alar width are really a pertinent part of your orthognathic exam, then by all means, like say that. But my approach personally would be like going after the really prominent stuff. Like there's an open bite, possible transverse discrepancy, elongated lower facial third, all that main stuff. And you called out, some malar, decreased malar projection, retrognathia. I thought your diagnosis was just fine. Open bite is kind of tough to say. Class 2 occlusion without measuring transverse discrepancy and some decent measurements might be tough to tell skeletal versus dental immediately, but I think skeletal is a perfectly fine cause here or origin.
Hey yo, I gotta sharpen my swords for the oral boards. I learned them from Patel and he's the Lord. And I'm his protege, I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go, ooh, ah, like some afternoon delight. Yo, I got these questions in my sight and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.